The following podcast is part of a certified educational activity titled Navigating MOGAD, Case-Based Insights into Diagnosis, Treatment, and Management of Myelin Oligodendrocyte Glycoprotein Antibody-Associated Disease. Access the entire activity and complete the post-test at peerview.com/FHM860. Downloadable slides and practice aids are also available.
Okay, well, hello, everyone. I'm Michael Levy. I'm an associate professor at Harvard Medical School and director of the Neuroimmunology Clinic and Research Laboratory at the Massachusetts General Hospital in Boston. Thank you for joining this unique case-based educational activity on diagnosing and managing MOG antibody disease, myelin oligodendrocyte glycoprotein antibody-associated disease. The goals for today are to prepare you to apply the latest diagnostic guidance, to improve your skills in recognizing and assessing MOG antibody disease, and to enhance your competence and confidence in preventing and managing relapses. All right, so first we're going to start with diagnosis. So where does MOG fit into the big scheme of demyelinating disease? Well, in the Western world, if you consider all cases of demyelinating disease, you can see on the far left, the vast majority of cases are still due to multiple sclerosis. Probably more than 95% of demyelinating disease in Western populations is MS. But then there's this wedge here of these non-MS cases, and it used to be that the only antibody we had to test for a non-MS demyelinating disease was the aquaporin-4 antibody that diagnosed neuromyelitis optica spectrum disorder. And so then if you picked out all those cases that were aquaporin-4 positive or MS, then all that was left was this wedge of non-diagnosable things. And it turns out a lot of those cases were testing positive for the MOG antibody. And now that we recognize that MOG antibody is its own distinct demyelinating condition, it's not a type of NMO or a type of MS, it's its own demyelinating disease, but it does overlap clinically with NMO and MS. We now recognize it as its own condition with very distinct clinical features as shown on this pie chart here. So first you can tell here that more than half of cases at onset will present with optic neuritis. Okay, so more than half of all cases of MOG antibody disease will have either unilateral optic neuritis or bilateral optic neuritis. So both optic nerves, and this is much more of a higher frequency than even NMO. We used to think NMO presented with a lot of bilateral optic neuritis. It doesn't even hold a candle to MOG antibody disease, which is much more common. And then there are other presenting features of MOG. In kids, for example, more than half of cases of acute disseminated encephalomyelitis, or ADEM, more than half of those cases are MOG antibody positive. And the reason 18% of all MOG attacks end up as ADEM is because there are a lot of children who present with MOG antibody disease. It's not just a diagnosis in adults. And then the rest of these presentations are all different forms of transverse myelitis, both longitudinally extensive and short transverse myelitis lesions, and then a large number of these cases of simultaneous optic neuritis and transverse myelitis. So you can see clinically, it does really overlap with how NMO and MS presents. But as I'll show you, these cases that test positive for the MOG antibody are distinctly different, and they're different clinically, radiologically, and immunologically. All right, so we surveyed a group of people about what kind of symptoms they have with MOG. And as you can see here, there's a lot of overlap with MS and with NMO and other demyelinating conditions. Number one on the list was headache and eye pain. And this is probably due to damage from optic neuritis attacks, either in the perineural space around the optic nerve or the meninges, or even in the fat around it. Inflammation in those areas can cause headache and eye pain with eye movements, and it can last for quite a bit of time. Even long after the treatment is done, some patients will complain of continued headache and continued eye pain. And then a large number of these other symptoms are due to attacks in the spinal cord. So long after your transverse myelitis is treated, You might still have symptoms of tiredness, fatigue, tingling, sensory loss, bowel and bladder problems, back pain, and of course, trouble with walking. Then there are kids who have ADEM and some adults also who have a few brain lesions, and that can lead to seizures, confusion, memory problems. So this survey really highlighted all of the common symptoms that MOG patients get from attacks of the optic nerve, which is by far the most common, attacks of the spinal cord, and also involvement of the brain. Now, if you had to compare and contrast among these three conditions, MOG, aquaporin 4, and MS, they're really different. So they all have a different antibody or no antibody in MS. The pathology is distinct. The onset is different. Kids are much more likely to have MOG than NMO or even MS. The clinical course can sometimes look the same. As I said, they all get optic neuritis sometimes and transverse myelitis. And so you can present with some of those very same symptoms of vision loss, pain with eye movements, and that kind of thing. And then you treat with immunosuppression, and they tend to get better. So MOG patients get a lot better. Aquaporin 4 patients get a little better, and MS patients get better over time. Of course, location of lesions, optic nerve is by far the most common in MOG. In NMO, it's spinal cord and optic nerve, and in MS, it's the entire neuroaxis, especially the brain. The brain MRI in MS has those distinct Dawson fingers, has central vein signs, slowly evolving lesions, and pearls. We don't think those are present in MOG and aquaporin 4 disease, but those studies are still ongoing. Then if you still can't figure it out with the antibody testing, brain MRI, and clinical features, you can also add to that the CSF testing. In MOG, they rarely have oligoclonal bands. In NMO, it's even rarer. And in MS, of course, we do expect to see them in more than 95% of cases. So in 2023, a group came together to publish the diagnostic criteria for diagnosing MOG antibody disease. And this is the most important table chart in the paper. And what it shows you is that there's three parts: Part A, Part B, and Part C. Part A says that patients have to present with a core clinical symptom. You can't have the disease without a symptom. And those symptoms are the ones we talked about: optic neuritis, symptoms from optic neuritis, transverse myelitis, acute disseminated encephalomyelitis, and then also brain lesions. Brain lesions do occur in MOG. We recognize that. And so if a patient has symptoms from lesions in any of these areas, they've qualified for Part A. Part B is the objective measure of the link to MOG. So you could do that either by having a strong positive MOG antibody test, what we call clear positive, and that's a titer of 1 to 100 or more on the cell-based assay, but it varies lab to lab. So a very, very clear positive antibody test, high titer, then you're done. A core clinical symptom plus a clear positive, you don't need anything else. If you have a low positive, or you don't know what the titer is, or the CSF is positive but the serum is negative, and everybody's thinking, is this really MOG or not? There's an added level of criteria, and that is, first, make sure that there's no aquaporin 4 antibody because of the known overlap. And then second is you need at least one of these supporting clinical or MRI features below. And that's here. For optic neuritis attacks, they need to be very clearly inflamed. So perineural optic sheath enhancement, that's what causes the pain I mentioned. Even optic disc edema is very common in MOG and not so common in NMO. So that's what helps distinguish. With spinal cord lesions, long lesions, or an H sign, or especially a lesion down in the conus, those are classic for MOG. So if they have transverse myelitis, you want one of those three. And then if they're brain lesions, then we provide some guidance here for distinguishing MOG from MS, but it is definitely harder than it seems in every case. And there are a few cases where we end with overlap, where we say, well, it meets the minimal criteria for MOG, but we can't rule out MS. It still looks like it could be MS. And that's where Part C comes in. Part C says you have to be, if there is a better diagnosis, like multiple sclerosis, then you can't make the diagnosis of MOG. But in the MS criteria, it says the same thing. If there's a better diagnosis and you can't make the diagnosis of MS. And that leaves a few patients stuck in the middle that really, really look like MS and do meet the criteria for MOG, and we're still not sure how to sort those cases out yet. I would say that's the vast minority of cases, 5% or less. Most will meet these criteria. So if you're sure about your patient that's presenting with an acute MOG attack, no doubt about the diagnosis, then here is what we recommend as first-line treatment for a relapse. So patient comes in, actively inflamed optic nerve. The first line is methylprednisolone. You have 1,000 milligrams a day for 5 days, and then a prolonged oral taper. Don't forget the oral taper. If you forget that taper and you just send them home with 5 days of IV steroids, they will rebound. There's a steroid withdrawal effect that I'll show you on the next slide that causes the patient to have another attack 2 or 3 weeks after exposure to these high doses of steroids. So make sure you do a 6 to 8 week prolonged oral taper. Most MOG patients will respond to this, of course. If not, then there are 2 other options. One is plasma exchange, 1 to 1.5 volumes. You do it 5 times, usually every other day, to avoid depleting blood clotting factors. That always works. Plex is wonderful. Plex works for aquaporin 4, for MS, for any demyelinating disease. So if you're unsure about the diagnosis, you're still kind of wondering if it really is MOG, Plex is a great option. If you're sure it is MOG, you do have another option to use intravenous immunoglobulin, IVIG. We use the higher dose, the 2 grams per kilo. This is ideal body weight, not actual body weight. So you go by the height, age, and the sex of the person, calculate the ideal body weight, and then multiply that times 2, and that's how many grams you want to give. And that's for the acute treatment. You only need 1 infusion. If you can fit it all in, we usually infuse up to 90 grams a day, so you might have to divide it up. If your patient is a full-grown adult, they may need 120 grams. You could do 60 and 60 over 2 days. And that should do it. So either steroids or IVIG, or steroids plus IVIG, or if you're not sure, you can always do Plex. Those are the standards of care for management of acute relapse in MOG. Now, what happens if you don't do the oral prednisone taper? If you give high-dose steroids and then you don't do a taper, this is what happens. You get a rebound, shown here in green, within the first 5 months of 40 cases in this study out of Australia. A large number of patients in this series had a rebound in their MOG attacks after withdrawal of steroids. So that's the most potent trigger for a relapse, and the highest risk time is in those first few months after stopping steroids. But even if you do wean, you got to wean slowly, because look what happens at the prednisone dose here in the purple bars. As you come down below 20 milligrams, the number of relapses goes up. So even if you are doing it correctly and you are weaning slowly, there's also a chance of relapse. And when does that steroid effect go away? A year, a few months really is really the highest risk time for a steroid withdrawal effect. And then after that, we don't tend to see any more effect there. So the steroids do wear off, and that risk of a steroid rebound goes away. Now, we don't like steroids. We try to avoid them if we can because of this high risk of rebound. And to do that, we've been using IVIG. We put our cases together with a couple of other groups. We got a total of 39 cases of people with MOG attacks. Now, we know that they already have MOG. These aren't new cases. These are people who we already knew have MOG, because IVIG doesn't work great for NMO. It doesn't work great for other causes of optic neuritis, neurosarcoid. So we really wanted to make sure these were NMO. We wanted to make sure that these were MOG patients. And they had all kinds of different phenotypes, mostly optic neuritis, but some brain attacks as well. And then we used different formulations of IVIG. You could see the range here goes anywhere from 0.8 grams per kilo all the way up to 2.4 grams. And most people were getting 2 grams per kilo. And most people were getting concurrent methylprednisolone. So when you do that, when you do steroids plus IVIG, that really results in a very good outcome. You could see this is a 30-day first follow-up. Their EDSS score goes from 4, which is blind in one eye, down to less than 2, which is much improved vision. And you could see the visual acuity score in parallel here. And it turns out this is good even without steroids. So you don't have to use steroids. And if you use IVIG, you can prevent that steroid with withdrawal risk. So if you give IVIG at the same time, you can taper that prednisone quickly and you don't have to worry about withdrawal attack. Now, after that, so patients got treated, they have a diagnosis of MOG antibody disease, then they come back to clinic. They made a fairly good recovery, as I showed you. After 30 days, people tend to recover. People with MOG, especially after the first attack, they come back in, they can see again, but now they're kind of freaked out. This doesn't happen to everybody, that they lose vision in one eye. So now you have to tell them, okay, you have the MOG antibody, and we have treatments for prevention, but a full 50% of people with that first attack of MOG will never have another attack. Their MOG antibody will probably go away over time, and they won't need treatment. So how do you tell who is going to be in that monophasic group and who's going to need preventive treatment? There's no way to tell. People have looked, we've looked, other groups have looked. There's really no way to know. The MOG titer doesn't tell you anything. The extent of the lesion doesn't tell you anything. The age of nothing. There's no prediction that we know of, no predictive tool that tells us that a patient is going to be relapsing or not. Now, we believe, and we've been pushing this on our patients, that if you go on a short course of preventive therapy right after diagnosis, so you have your first attack, and then you take 3, 6, 9 months of treatment, preventive treatment, to really put the disease in remission, we've seen a better outcome long-term and reduced risk of relapse. But these are 2 to 3 year durations, so we're not 100% sure what long-term follow-up looks like in these people and whether we're really making a long-term impact. Because otherwise, we don't really know who to recommend preventive treatment for. Now, if a patient comes in with their second attack, 3 months or more after their first event, not triggered by a steroid withdrawal, that is a reliable case of relapsing MOG. And those patients are going to have a third, fourth, and fifth attack. And those people would be ideal for preventive therapy. So what are we using for preventive therapy? Well, currently there's nothing approved for MOG antibody disease. But just like with NMO before approval of 4 drugs, we start with off-label treatment. Off-label treatment are treatments that we just try on people, and if they seem to work, then we talk to each other at conferences, put data together and say, wow, this really seems to work. And this open-label observational effort with a lot of centers, IVIG has emerged as the #1 treatment. You could see here there's even a dose-response effect. With a 1 gram per kilo dose, there's a 60% response rate, meaning about 40% failure rate. But with a higher dose, there's a nearly 80% response rate. And then you could convert that high dose into subcutaneous IG, and it seems to work just as well. Now, how long do you have to treat with IVIG? We're not sure. A lot of patients don't like it. It causes headaches, it's infusions, it's expensive. And so we try it for 6 months, 12 months, whatever the patient can tolerate. And then we'll follow up MOG antibody levels. Because if the titer really goes down and goes away, that's a reassuring sign that they're not going to relapse long term. So that's probably our only reassuring sign. Everything else doesn't tell us about whether stopping IVIG is going to result in a relapse or not. So that's the only thing we follow. There are alternatives to IVIG, which costs $20,000, $25,000 per month in the United States, so very expensive. There are lower cost alternatives. The most popular is mycophenolate. This is a very low cost drug. We use it at about 1,000 milligrams per meter squared body surface area daily. And that ends up being, somewhere in the range of 1,000 milligrams twice a day, for example. And we can follow absolute lymphocyte counts to try to dose it correctly. We also follow liver function tests to make sure it's not toxic. Now, beyond these two, we've been using a little bit of tocilizumab lately. That's an IL-6 drug. And when all else fails, there's always prednisone. I try to avoid prednisone whenever I can because of that steroid withdrawal effect. Plus, if you get a MOG patient hooked on prednisone, using it for at least 3 months or more, they're really going to be stuck on it. Meaning every time you try to wean down the dose, even to 15 milligrams, just a little wean, they're going to have symptoms and even a flare. And it's really hard to get those patients off. You got to put them on IVIG and then bring them off of prednisone. So I really try to avoid prednisone when I can. Tocilizumab, I just mentioned, is supported by a few observational studies. You could see tocilizumab here in blue. These are 14 patients who have multiple relapses before time 0. Initiation of tocilizumab, you can see most of those relapses have gone. There are a few patients here in diamonds that do relapse and fail tocilizumab, but most have responded. And that has resulted in a phase 3 trial for IL-6 therapy with satralizumab. That phase 3 trial is enrolling worldwide. There are 2 trials enrolling worldwide that are placebo-controlled for an indication to get approval from regulatory agencies. Both are enrolling. I'll go through both rozanolixizumab and satralizumab in a little bit more detail. I just want to mention that tocilizumab is being trialed in some settings, like in China, and azathioprine is being trialed in France. These are not necessarily for approval, but more like phase 2 proof of concept that they work. Okay, so the first trial that launched uses a drug called rozanolixizumab. This is a drug that targets the FcRn, the neonatal Fc receptor. These receptors are found on the surface of endothelial cells all over the body. Their job is to hold on to antibodies in circulation, to hold on to them so that when the plasma is recycled and everything is sent for destruction, the antibodies are saved, sent back into the plasma. This is how your plasma is recycled on a regular basis without losing antibodies. Now, this drug, rozanolixizumab, it binds that FcRn, so antibodies can't be saved. And antibodies get destroyed along with the regular plasma recycling. And it works fairly quickly. Within a day or so, those antibody levels will drop. It's almost as effective as plasma exchange. You can think of it as like an intravascular plasma exchange. This drug is already approved for myasthenia. It's being developed for other conditions. And because MOG appears to be so IVIG responsive, anything where IVIG has been developed, rozanolixizumab seems to work for. So they jumped into MOG and initiated a phase 3 trial. They're enrolling 104 participants. It is double-blind in the initial phase, so that means patients don't know what they're on and doctors don't know what they're on. But if a single relapse occurs, then they roll out into the open label phase and they get the drug for sure. So nobody's allowed to have more than one event. And that's a little bit of reassurance to patients who are worried about being randomized to the placebo arm and having multiple events. That won't happen. It's just one attack and then you're out. As I mentioned, the neonatal Fc receptor helps to hold on to those antibodies. And if you block it, you get a quick depletion of antibodies. This is now approved for myasthenia. Here's demonstration in a mouse model of MOG antibody disease, where the higher the score, the worse the mouse is doing, the worse the clinical score. And as you can see here, this is the control group, gets worse. And this is the group here with the arrows you could see when they were treated. You can see the treated group has a better outcome. So even in the acute setting, it appears to help, but really the goal here is to prevent relapses. So these patients get infused. It's a subcutaneous infusion. They get one infusion every week or so. And we do monitor levels. It's a blinded study, but the levels of antibody are monitored so they never go too low. And if they go too low, then they skip a dose or they get a placebo dose. So that's how that's monitored. Okay, then the second trial that's phase 3 worldwide is with satralizumab. Satralizumab is a drug that blocks the IL-6, the interleukin-6 receptor. Interleukin-6 is thought to communicate chemically between T cells and B cells and to initiate a pro-inflammatory response. So by blocking the IL-6 receptor, you have an anti-inflammatory mechanism. And satralizumab is already approved for aquaporin 4 NMO and is now being trialed in MOG. And I showed you some of the data with tocilizumab, which is an older version of the IL-6 receptor blocker. Tocilizumab is dosed at least twice a month, whereas satralizumab is dosed only once per month. They're both subcutaneous dosing. The goal here is to recruit 152 participants. After a short loading dose, it goes to a single monthly injection. They're hoping to complete their enrollment by 2026. And the study design is exactly the same as rozanolixizumab. There's a placebo arm, but if a patient in the blinded phase of the study has a relapse, they're automatically removed from the double-blind phase, and they go to the open-label phase and definitely get drug from then on. And both of them are going to have outcome measures of time to first attack. The expectation is that both satralizumab and rozanolixizumab would prevent those attacks, and the placebo group would in each trial would accumulate attacks in the placebo arm, and then over time, as they're moved into the open label phase, there'll be no more attacks. There is some data supporting blocking IL-6 in MOG antibody disease. These are measurements of the interleukin-6 cytokine. These are in the cerebrospinal fluid of patients with relapse of MOG, voclosporin-4, MS, and controls. You can see the levels of IL-6 are very high in MOG, in many cases of MOG attacks. They're also elevated in aquaporin-4 disease. As I mentioned, it is approved for prevention of attacks in aquaporin-4 disease already, and now they're going for the MOG indication as well. Both of them have safety as a secondary outcome, with some preliminary from other studies like in NMO and in myasthenia, preliminary reassurance that these drugs are relatively safe, no major safety signals. So we've gone over diagnosis, we've gone over the treatments, and we've gone over the trials that are ongoing. Now we'll discuss how to apply these concepts in practice with a couple of patient case scenarios. Okay, so we're going to start with a 4-year-old. This 4-year-old is brought in for a headache that was noted a couple of days ago, and then very recently some imbalance and kind of clumsiness while walking around, and then a seizure that occurred this morning. So as soon as the seizure was over, the kid was confused. The parents brought the kid in the very next day. And obviously, this is involving the brain. So neurologists, the first thing we do is we localize the disease. This is localizing to the brain. There's confusion, ataxia, headache. So the first question is, how would you approach assessing and diagnosing this case? Obviously, the first thing we would do is we would scan the brain. In this case, it would probably require anesthesia because of the age, 4 years old. They probably won't sit still in an MRI. So you put them under anesthesia, get the MRI, and most likely in this case, what you would see is an acute disseminated encephalomyelitis event. You'd see big, fluffy lesions. Some of them might be enhancing. They'd be on both sides of the brain. There might be optic nerve involvement. There might be spinal cord involvement. And that is the classic presentation for acute disseminated encephalomyelitis. Obviously, the therapy that would be started right away is acute steroids, methylprednisolone. Sometimes people just go straight to IVIG if they're confident in the diagnosis, because most cases of ADEM are MOG positive. And we know that ADEM responds very well to IVIG as well. So maybe steroids, maybe IVIG, maybe both. And that's the current state of the field with acute disseminated encephalomyelitis. Now, the MOG antibody test is going to be sent. Obviously, this kid has no prior history, so we don't know when this, we don't know that this is a second event. We don't know that there's going to be a third, fourth, or fifth event. With just one presentation of ADEM, we still call this a monophasic presentation. And the risk of relapse is fairly low. So after one ADEM, the risk of relapse is thought to be around 10% or so, but it also depends on the MOG antibody. So if they're MOG positive ADEM, the risk of relapse is a little bit higher. It's not quite 50-50. There's probably a better outcome for these kids, especially with a few months of treatment. So these people are going to get steroids, IVIG, and if you keep treating them for 2, 3, 4, 5, or even 6 months, then their risk of future ADEMs or future optic neuritis events is going to go down. But that's something that we'll continue to monitor over the long term. We'll check MOG antibody levels at 6 months, at 12 months, and beyond. As long as they're still positive, we'll want to keep an eye on them. If the MOG antibody goes negative, again, that's very reassuring. You don't have to keep them on treatment. Keep an eye on them for another couple years, and then they're probably good to go. And recovery after ADEM in about 90% of kids is complete. In about 10%, there's some lingering damage, and those could be ongoing seizure issues, attention deficit, a little bit of confusion or ataxia, depending on where the lesions were and how much damage was done. Okay, now what if instead of a 4-year-old, we're dealing with a 13-year-old? And this 13-year-old girl presents with sudden vision loss and orbital eye pain. So pain with eye movements, soreness right behind the eye. How would you approach this case? This is a very common presentation of optic neuritis. So usually these patients will come through ophthalmology or optometry. The ophthalmologist will examine the eye. They'll see everything is normal with the eye. And so then they know that the problem with the vision is due to the optic nerve or further back. And that'll prompt an MRI, often an inpatient admission for something like this because of workup for MS. So about half of cases of optic neuritis will turn out to be MS. Not necessarily in kids, but in most cases. So we will get a full brain MRI to evaluate for multiple sclerosis as well. Of course, we'll send the MOG antibody, send the aquaporin 4 antibody, and those take about 10 days to come back. So for most cases of optic neuritis, they are either MS or idiopathic optic neuritis. We treat with high doses of steroids and a short prednisone taper. If you know for sure that this is a MOG case, then you know you need a more prolonged taper, or you can use IVIG. Now, first thing you do is you get the brain MRI. If you don't see any evidence of MS, you might want to do a spinal fluid analysis to look for oligoclonal bands. If you don't see any oligoclonal bands, then you're pretty sure that it's not MS. It could still be MOG. You have to wait for the MOG antibody test. It could take 5 to 10 days to come back, or it could be monophasic optic neuritis. So the long-term implications depend on what the diagnosis is. If it's MS, there's a track for that. We have 24 approved drugs for multiple sclerosis, MS clinics for kids. All the resources are there. A referral is necessary in those cases. If it's monophasic optic neuritis with no evidence of MS, MOG negative, everything negative, 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 you can keep an eye on them as they make their recovery and see if there's any future relapses in the next 2-3 years. If the MOG antibody test does come back, then you know this person has about a 50-50 chance of a relapsing disease. You can treat for a prolonged period of time, especially if they started with steroids. You don't want to suddenly withdraw them. You can treat for a prolonged taper, or you can use IVIG, and you really want to try to push this disease into remission to maximize their likelihood of a monophasic disease course. You have to keep an eye on them for 2-3 years, still even beyond the treatment period, because those are the chance of relapse could occur at any time. We even had an older lady at 75 years old come in with her second optic neuritis. Her first optic neuritis occurred at age 25, 50 years prior, and she tested positive for the MOG antibody. So there are no guarantees. Of course, I wouldn't have told that 25-year-old to worry about anything over the next 50 years. That's crazy, but it can happen. And then the third case is a grown-up, a 35-year-old, who comes in with blurred vision in one eye and also a urinary incontinence. And so this is a simultaneous presentation. This is sort of the classic presentation for neuromyelitis optica that was described more than 100 years ago that kind of distinguished these demyelinating conditions from MS. So people who have two localized events, one in the optic nerve, one in the lower spinal cord, they were recognized a long time ago to be different from MS. This was the original description of neuromyelitis optica, and now we have two antibodies, both aquaporin 4 and MOG. So a patient like this with the classic presentation, they'll get both antibodies checked. Now, again, even though this is the classic presentation of NMO and MOG, you still want to get a brain MRI to look for MS. MS being by far the most common demyelinating disease. It could still be just a chance presentation of MS. So brain MRI, antibody tests, and then probably spinal fluid analysis as well to rule out MS. And then the treatment is going to be, since you don't know the antibody status, it's going to be high-dose steroids. And then depending on how much recovery there is, you might want to do plasma exchange. And plasma exchange would cover attacks of all demyelinating disease, no matter what it is. If you still don't know what the antibody test is, and she's still blind in one eye, and she's still having urinary incontinence, and you want to pursue that escalated care, that would be best done with plasma exchange here. Because if it's aquaporin 4 in the end, and you do IVIG, it's probably not going to help. So you start with plasma exchange. Of course, if the lab calls and says, oh, this is a MOG antibody positive, you could always fall back on IVIG. Risk of relapse here is exactly the same as the previous 13-year-old, 50-50 chance. If it's MOG antibody positive that they'll relapse, you want to put them into a deep remission, try to maximize their chance of a monophasic disease course. And then you have to keep a close eye on them. You don't have to follow them for 50 years, but at least 2-3 years. If they remain monophasic off of treatment for that period of time, then they're probably good to go and they can just call you if a problem comes out. So in summary, I hope I've convinced you that MOG is a distinct disease. The antibody test, by the way, was only available in the US since 2017. So all of this data that I showed you is really only collected in the past 7 years. And so we're still learning a lot about the diagnosis. It can still be a challenge to diagnose and to distinguish it from MS. And there's a lot of clinical overlap. That makes the diagnostic process a little bit challenging. But we have good antibody tests, especially for aquaporin 4, and the MOG antibody test is improving. And while we don't have approved therapies for MOG yet, we expect those to roll out in 2026 through 2028. And we do have off-label therapies that we've fallen back on, including IVIG, mycophenolate, tocilizumab, and if you have to, there's always prednisone steroids. So we'll keep an eye on those phase 3 trials and hopefully have some approved therapies soon. So that brings our discussion to a close for today. I hope you found the activity informative and useful to your practice, and I encourage you to access the supplemental program materials. Thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from UCB Incorporated. To access all materials for this activity, visit peerview.com/FHM860.